Welcome. I am Dr. Nadine Jackson McCleary. I am a physician at Dana-Farber Brigham and Women's Cancer Center. I'm also an assistant professor at Harvard Medical School, and I am a medical oncologist within the Gastrointestinal Cancer Center. And today we will discuss topics related to colon and rectal cancer prevention and treatment.
Thanks, Dr. McCleary. For everyone who's watching, feel free to write your questions in the comment sections and we'll try to answer them all. Let's get started. What is colorectal cancer and why are colon and rectal cancers grouped together?
So colon and rectal cancers are cancers that affect the gastrointestinal tract. It's a part of our body that helps us to digest our food and to eliminate. These cancers arise in lesions that are described as polyps or growths. These are lesions that can be caught early if one has screening as appropriate with a colonoscopy and removed to reduce the risk of cancer occurring. Oftentimes these cancers can be prevented and they can be cured. Colon and rectal cancers are joined together when the treatment is similar, which typically occurs when the cancer is advanced.
Thank you. What have incidence rates been like in recent years?
Incidence rates have been relatively steady for most populations of patients. Over 100,000 patients are diagnosed with colon cancer every year in the United States. 40,000 are diagnosed with rectal cancer, and 50,000 will die of this disease every year. However, in some populations of patients, the rates of cancer are higher than in others.
What might increase a person's risk for developing colorectal cancer?
There certainly is a concern for an inherited cancer syndrome or risk factors that you inherit from your parents within your family that could increase your risk of developing cancer early or even later in life. There are also a number of lifestyle habits that are associated with worse outcomes for those who are diagnosed with cancer, early occurrences, and worse response to treatment.
It's very interesting. So can colorectal cancer be prevented? And if so, what are the steps that an average person can take to prevent colorectal cancer?
So remember I mentioned those lifestyle habits. So one of the lifestyle habits that we favor here, exercise, a plant-based diet, those are very important and can help reduce your risk of contracting cancer, but also reduce your risk of cancer progressing and also improve your response to treatment moving forward and your recovery after surgery and also tolerance of treatment. All of those are very important factors for us when treating patients with colon and rectal cancer. Other factors include getting early screening. So currently the age guidelines is age 50 for patients who have an average risk of developing this disease, and 1 in 20 will develop this disease within their lifetime. But there's also a risk for those who have an inherited cancer syndrome and they may require screening earlier in life.
Is colonoscopy the only way to screen for cancer?
It's still the best and most appropriate way to screen for cancer, although there are other appropriate modalities as well. It really depends on what your risk is. There are endoscopy procedures that do not evaluate the full colon and evaluate only a portion of the colon, like the sigmoid colon. So a sigmoidoscopy may be appropriate for you. There are also other tests that we will use, like fecal occult blood testing, which is looking at the stool for any microscopic evidence of bleeding. And that could also let us know that there's a risk of cancer present and prompt us to do a colonoscopy. And then lastly, I would mention there have been efforts to use scans instead of the endoscopy procedures so we can avoid the prep that sometimes is challenging for patients. But still, in the end, colonoscopy is always going to be the most appropriate and complete way to evaluate the intestinal tract.
Thank you. What is the usual treatment for colorectal cancer?
So the treatment for colorectal cancer depends on the extent of disease, how many parts of the body are involved, and it also depends on where the cancer has occurred. So a cancer that is started in the colon, if it is caught early, typically is treated with surgery first, and then depending on the extent of involvement that is seen at the time of surgery, then treatment may be recommended. And often those cancers can be cured. If the cancer involves the rectum, depending on the extent of involvement, one may require chemotherapy and radiation therapy before surgery, and then possibly chemotherapy after surgery to cure the disease. For some patients, their diagnosis comes later, and colon cancer is advanced. At that point, we would call it colorectal cancer. And at that point, chemotherapy is the primary treatment, although some patients are still able to undergo surgery and possibly have cure of their disease.
Thank you. That's a lot. What are some things to consider then when deciding where to go for colorectal cancer treatment?
So one thing that's very important to us at Dana-Farber is the multidisciplinary approach to care, in that we include a number of very expert professionals in the field who are knowledgeable in how best to treat cancer. The research area that we are advanced in also helps us to treat cancer and approach patients with the best treatment recommendations. So we pull together our researchers who are working on experimental therapies in the lab and novel approaches to treatment in the lab. We pull together our clinicians who know how to deliver the therapies in a safe and effective way. We involve our supportive care providers as well to ensure that patients have the best quality of life possible. And those things are important decisions in terms of this journey of care, not only the diagnosis, but the treatment and also recovery and surveillance over time. One of the things that I think is also very important is making sure you're evaluated by those who understand this disease, the complexities of the disease, and how best to coordinate care to ensure the best outcomes from treatment.
Thank you. Is there any new research in the field? And if so, what are the latest findings?
There are several areas of research that are being explored. One of the many areas that remains of interest is how best do we deliver therapy to reduce the risk of toxicity with the chemotherapy that we offer. Many of those studies were started here at Dana-Farber. One study that is ongoing is the PROSPECT trial, evaluating patients who are diagnosed with rectal cancer to understand if we can eliminate radiation therapy prior to surgery because of new advances in chemotherapy. And that study is still underway. There's another study that was recently completed that we were a part of, and one of our investigators here led the national effort, and we joined forces with colleagues in Europe and elsewhere to understand what the duration of therapy should be. And for some patients who have a lower risk of cancer returning, duration of therapy can be reduced by half. So those patients are able to receive a shorter course of chemotherapy of 3 months instead of the prior recommendation of a full 6 months, while 6 months still may be appropriate for those with a higher risk of cancer returning. We've also had studies exploring complementary therapies as well as diet and lifestyle habits. And many of those studies have shown the benefits of cancer as well as a plant-based diet. And a recently published study involving consumption of nuts to reduce the risk of cancer recurrence in patients who've had curative resection of their cancers. And then lastly, there are novel therapies exploring areas such as immunotherapy and understanding how those therapies can be either combined with other forms of immunotherapy or other chemotherapy regimens to optimize outcomes for patients.
Are there any advancements on the horizon that you're particularly excited about?
I'm excited about all of it. I think most important is how do we help our patients in tolerating therapy? How do we bring together the best areas of study and the best experts in the field to develop the best and novel regimens for treatment, but also how do we support our patients in the entire journey. Preventing disease being a very, very important area of exploration currently, but as well as novel therapies, including immunotherapeutics.
Thank you. We have a question from one of our viewers.
Sure.
Do you recommend Cologuard stool testing?
So I can't officially recommend or not recommend any particular test. However, I think there's a role for many areas of testing, and that is one of the first levels of testing that may be helpful. Still, a colonoscopy is going to be required to help us understand the location of the tumor, the extent of involvement, and to be able to perform the biopsy that is needed to confirm the diagnosis. I would also add that much of the information that we receive from the biopsy now helps us to direct and target our cancer treatments. And so a part of what we have done at Dana-Farber Cancer Institute, among other institutions, is sequencing of the tumor to understand what the target should be for treatment and how best to tailor our therapies moving forward.
Okay. Dr. McCleary, can you speak a little more about immunotherapy? We've been hearing a lot about that in the news, that you can train your immune system to fight cancer. How does that work again for colon? You mentioned it before, but could you elaborate on how that works for colon and rectal cancers?
Sure. So immunotherapy is a class of agents that essentially helps us to use our body's own immune system to target and to treat the cancer. It is a new area of exploration, although there have been approvals in other cancers, but within gastrointestinal and particularly colon and rectal cancer, it's not as well defined. There are a subset of patients whose tumors are unstable and express some genetic instability. And for those patients, the FDA has approved a particular type of immunotherapy for use in those patients immediately who have advanced cancer. But for the majority of patients, immunotherapy is still something that is being explored in clinical trials. And here we encourage our patients to consider participating in those clinical trials so that we can best tailor our treatments for their cancer, but also learn more about how we tailor those treatments for others as well. Many of those trials would include immunotherapy drugs by themselves or in combination with other drugs that target other paths in the cancer growth mechanism, and also a combination with chemotherapy regimens as well.
Thank you. In your practice, how have you seen, with all these advances, how have you seen colorectal treatment change over the past 5 years?
Over the past 5 years, so for colon and rectal cancer, when I started in my training, the two approved therapies were combinations of chemotherapy alone, and we recently added a targeted therapy at that time called bevacizumab. And we're beginning to explore another targeted agent that targets patients who have a lack of a mutation in a particular path called KRAS. And there are two drugs in that area, cetuximab and panitumumab, but that was really the limit of therapy that we had to offer that was approved for patients. Outside of that, patients had to rely on experimental therapies, and there were few to offer. Since that time, there have been approvals of at least 3 to 4 other agents, depending on the sequencing data we have learned about a patient's tumor, that could be deployed as approved therapies, including regorafenib, zivaflibercept in combination with chemotherapy, Lonsurf without additional chemotherapy. So those are all agents that have been approved since that time, and there are more therapies that are unfolding, including immunotherapy, as we've just discussed, with some patients having approval to receive that as a part of their treatment right away, and then more in terms of clinical trial combinations.
That's exciting, thank you. We have another question from our audience. Do you see recommendations for screening changing in the near future as more patients are diagnosed at a younger age?
So that brings up a very interesting point. We do know that if we look back to the 1990s, maybe 6% of our patients were diagnosed age 40 or younger, and that number has increased over time to about 11%. Still, the majority of patients diagnosed with this cancer are in the older group, in that 50% of patients are diagnosed at age 70 or older. But it is an interesting observation, and we're still trying to understand what the mechanisms are that would explain the shift or observed shift in age to a slightly younger subset of patients.
Thank you. Dr. McCleary, thank you so much. We don't have any additional questions. They came from our audience, but so we're going to wrap up our discussion, but we want to thank you for the time that we were able to spend together. And for those listening to watch this broadcast, I should say listening, those watching to watch this broadcast again, you can find it on Facebook, on our Facebook page. And to learn more about colorectal cancer at Dana-Farber, please visit danafarber.org/colorectal. Thank you for joining us.
Thank you.